Greetings. I'd like to welcome you to another installment of Hygia Today, an educational show series supported by Hygia Health Services. I'm your host, Dr. Alex Shaknovich. After a nearly 4-decade career as a cutting-edge interventional cardiologist, inventor, educator, researcher, and a successful clinician, I co-founded Hygia to bring AI-based technology and cutting-edge human expertise to enhance provider and patient performance and competence in healthcare. Today, we'll be focusing on the ever-changing and ever more complex regulatory landscape of an American healthcare ecosystem. And we're extremely fortunate to have with us someone who stands out even on our roster of Hygia experts in regulatory and compliance matters. I'd like to introduce to you Dr. Baran Erdik, who is a fellow clinician who completed a number of advanced degrees, including masters in public health, and then has had extensive experience as a CMS regulator, overseeing thousands and thousands of reviews and surveys of hospitals and practitioners. Welcome, Dr. Erdik.
Thank you, Dr. Shaknovich. It is my absolute honor to be here with you today. I've been enjoying working with Hygia, and as an expert and as someone who's worked in healthcare regulations for years, it is my absolute honor to be here. And honestly, there's lots of changes coming. There's been lots of changes coming probably since the ACA, but I think the last couple of years, especially after the SARS-CoV-2 pandemic, we are looking at even more so changes at an accelerated pace, so as to say, maybe to catch up.
Well, you've touched on my very first question. What are the most important changes in the regulatory milieu of American healthcare in 2023?
You know, I always like to start with the bad news. It is that the purse strings are tightening more so. There's been the push in the last couple of years to slowly lower physician reimbursement. And I think we are just still seeing that. There's firstly the physician fee schedule. You know, the conversion factor has seen a decrease, and it is now at $32.74. So it is subtle, but I think that'll have profound implications for the economics and provider reimbursement.
Is that true for smaller practices as well as for larger healthcare systems?
You know, I think it is even more so true for smaller practices, because if you're a big fish, the size of the pond doesn't matter. You probably have a team that can help figure things out, that can help assist you sort out how to maximize your income streams, let's say. But if you're a small fish, barely hanging on maybe an independent clinician, it is getting really tough out there.
Mm-hmm. And is this something new? How does 2023 compare to the regulations of the previous years?
So there is a couple different aspects to this before we get to the changes for billing. I mean, for hospitals or ambulatory surgery centers, or like the MSSP, the Medicare Shared Savings Program. Think about it this way. First, the proposed cut is a 3.3% reduction. You have two things going into it. You have the temporary legislative update that is about half of it. I believe it's something about 1.3, 1.4. And then there's a negative budget neutrality adjustment. That's also associated with the new office visit add-on code, which we can discuss. So ultimately, that's following another 2% reduction coming in from this year. So, you know, we have the inflation rising, but year on year, we were looking at a 2% cut for this year, and we were looking at a almost 3.5% cut for next year. So it's just becoming really tough out there.
Thank you. Do you expect these trends directionally to continue in 2024, or do you expect perhaps a more favorable environment for providers?
You know, I think the the issue is ultimately stemming from what the goal of healthcare in the United States is becoming. If you think about it, we spend the most among OECD. Do we get the most? We unfortunately do not. The changes in life expectancy in the US in the last couple of years, granted, a lot of it is attributable to SARS-CoV-2, but it is just scary. So if you think about it, what are we spending this money on? And I believe after ACA, the CMS focus has been on quality. And with MIPS, they've tried this. They've tried hurting physicians without any penalties to do the right thing, but there's been a lot of holdouts. So I think with MIPS and possibly having you look at the positive aspects of things, meaning positive reimbursement changes as an increased percentage, and with the physician fee schedule going down from 33.89 in this year to 32 next year, I think that's going to be a continuing trend where they're going to want you to work for that increased reimbursement, where they're going to be wanting you to show how you can provide quality, not just acute health care.
Well, that actually sounds somewhat encouraging. While reimbursement may be coming down, correct me if I'm wrong, the emphasis is shifting towards quality of patient care and quality of outcomes.
Yes, it is. It would be another show with you probably that where we could debate whether this is all actually pushing quality. But I think personally, it is still better than nothing, right? We are still putting some benchmarks out there, and it is just like you're not just driving down the road blindly. You're at least now looking at the speedometer, whether you're doing 60 miles, 70 miles, you're at least trying to achieve something with it. And I think the ultimate push where the physicians will have to come to terms with is that there is also a lot of physician assistant or mid-level push, and the physicians will sort of have to become the team leaders instead of just a solo team player, and will have to start looking at disease less so acutely and more so from a chronic perspective, in that where if you're a cardiologist, you're treating STEMI, you will also need to more than consult the patient on weight loss, on active healthy living, on eating, just starting to take the patient as a whole, basically.
Again, I, as a clinician, I see these as positive developments. Transactional medicine, one aspect of it, relationship-based, more patient-dependent management of chronic illnesses, a huge chunk of American healthcare. If we could build on our experience from COVID, obviously during COVID, telemedicine came into its own. There are all kinds of new monitoring technologies and transmissions and data analysis opportunities that are now available. How do these regulatory changes encourage or impact on telehealth?
I guess we can talk about the telehealth first, right? I mean, it's been, first we had the public health emergency that had been extended up until this year, March, and some were supposed to extend later, some were supposed to expire later. But ultimately, the two main hindrances to this, I would say maybe even the main one, was coming from a DEA perspective. They had an in-person waiver that's basically if you were prescribing controlled substances, which if you look at it surprisingly, diagnosis of adult onset ADHD, it may not be adult onset, but we're diagnosing it in adults, so it's been termed that, as well as stimulants to manage touch disease have been going up and up. Some people have been attributing some part of it to COVID, which studies show us that it is true. But I think on the other hand of things, it is also that telehealth mainly has revolutionized patient access to, especially in psychological issues. It's made it more mainstream and easy to access, especially with such extensions of in-person waivers. So in 2022, we had the omnibus legislation that introduced various enhancements and relaxation of these geographic and originating site restrictions. And they were supposed to be running out this year, but again, these have been put on hold, and by the looks of it, it is just going to be put on hold up until next year. And at that time, I honestly personally expect that we will see further guidance and maybe even legislation and other regulatory changes to keep the status quo and to keep telehealth as is. I'm sure you can agree that ultimately it is easy to let the cat out of the bag. So if they let telehealth roam, it is way harder to put it back into the way it was.
Well, I want to remind our viewers that at Hygia we have a number of leading experts in this very complex regulatory terrain, and they're available for you to turn to for advice. Let's go back to the reimbursement side. How do these changes affect the processes of billing and reimbursement and collections for individual providers?
So interestingly, there's a new billing code. I don't know if you've heard of the new billing code, but from a billing process, not much is changing. From a billing perspective, again, not much is changing. There's just increased opportunities everywhere, right? You can bill for, let's say, chronic care much easily now, or you can bill for other services that may have been more restricted previously. I would say the largest change will be the new billing code that is been put on for family practice and primary care. And ultimately, you can also think about inclusion of maybe other types of services that have not been traditionally under Medicare, such as maybe marriage and family therapists. So I think we're seeing the same goal over and over again, which has been the AAA since the ACA, providing higher quality healthcare at a lower cost. And I think it just shows us that CMS is just trying to include a lot of different things, not just physician care.
Well, again, these are opportunities, but how do providers ensure their own compliance with these new opportunities? How do they adapt to these regulatory changes without worrying about going afoul of new rules?
So, people ask me this question all the time. It's an attitude. It's not a single thing. It's like, how do I take care of my car? I mean, you get in a car, you have to see if there are any check engine lights. That's your overview. That's your emergency situation. At every fuel change, it's recommended that you check your engine oil level. You check your tire pressures every week or so. I'm sure a lot of us don't do these things, but they're still in the user manual. It's the same thing with regulatory compliance. It's not a one-time thing. If you're looking to sort out compliance last minute, that usually tells me that there's something knocking on your door, or someone knocking on your door, or some agency knocking on your door. So at that point, it is a little bit too late, in my opinion. So I think the best way to do this is start anew. Look at, if you're a single clinician, start looking at maybe whether you were participating in MIPS or whether you were getting an automatic waiver due to the pandemic, due to the public health emergency. Beyond that, look at whether you've been penalized in any sort of way from your reimbursements. Look at whether you're trying to comply with any sort of the EHR or EHR data regulations or any sort of data sharing agreements, and that would be a good start. And this is, again, if you're a single provider, this is all going to be hard, and you will probably not have ample time to know all of this, to learn all about this. So it may also be prudent and smart to look for outside assistance, in my opinion.
Thank you. This is a very good overview of the overall direction of the regulatory environment. And certainly, again, experts like you and your colleagues at Hygia would be available for review and consultation as needed. What about the data management regulations, the regulations surrounding the electronic medical or health records and data sharing and the overall patient-provider relationships?
This is still ongoing and continuing. We had the 21st Century Cures Act. there were three main, so as to say, directives in there. You had the EHR certification updates. There was issues related to information blocking and the trusted exchange framework. So these have been progressively being implemented. So the quality payment program and other federal programs, they now need certified EHR. So this 2023 has been a major EHR transition year. So some like MIPS required 90 days of certified EHR, some didn't. It's still ongoing. Beyond that, from a data interoperability, data information blocking perspective, we now have regulations related to that. No one has been penalized, and I don't really see the small fish being penalized, but it's going to be interesting to see how those play out. And ultimately, we have the Sequoia project that they opened their application portal last year for the QHINs, the Qualified Health Information Networks, and we had the signings of common agreements and the onboarding. So it is in a toddler stage where it's starting to walk and learn how to walk, but it is definitely coming and it's going to start knocking on your door, and you probably want to start making sure that you're not blocking any information sharing.
So any new technology or any changes in operational planning that individual providers should be considering in the context of the changes in the regulatory landscape?
Again, the QPP and then the MIPS, you will, if you want to take part, if you want to do good, you will want to slowly start moving into certified EHR technology, and you will also possibly want to look at information sharing and then the qualified health information networks, so that ultimately you're fully on board for the next round of proposed regulatory updates.
I'm wrong, is that there is some recognition of the need to move with the times, to recognize the growing burden of chronic illnesses, greater role of patients in determining outcomes of their illnesses, and also the growing role of newer technologies. Any impact on drugs and pharmacy services?
Yes. We can talk about the changes to 340B, but before I get to that, interestingly, as you said, for EHR healthcare perspective, it's also becoming really important as you move everything to an electronic perspective. How are you going to keep track of your passwords, right? Are you going to write them down? It's all patient data. You have HIPAA, you have state regulations, and there's been a lot of cyber threats. So interestingly, it's one of the most interesting news I've read this year, probably from a regulatory perspective. New York State has proposed cybersecurity regulations for hospitals. These even supersede the federal ones, so and the HIPAA security rules. So basically, they're going to be funding close to $1 billion to ensure larger healthcare facilities have upgraded technology and have chief information security officers and have multi-factor authentication, like when you're accessing to your bank. So I think a lot of this will have to come down before you sort of get hacked.
Excellent. Well, thank you very much. This has been a wonderful overview of what admittedly is an often confusing and dispiriting part of being a physician in the United States. And I think you'll agree with me that it will continue to grow in its complexity and importance.
Correct. And as you just asked me, let me, I guess, just briefly touch on that too. So hospitals did get a rate hike. It's about 3%. Hospitals and ambulatory surgical centers. That is ultimately higher than what had been proposed earlier in the year, about 2%. So that's with the OPPS, the outpatient prospective payment system. Is it sufficient? It's debatable, but especially hospitals are not pleased. And ultimately, with that OPPS change, there's also changes to the 340B, the drug discount program. So there were payment cuts in it until 2022 from probably mid-2015, 2016. So CMS has agreed to pay a lump sum to every hospital under 340B. That's going to amount up to about $10 billion. So I think that lump sum will mean a lot to a lot of the hospitals. there's a catch that needs to be budget neutral. So I think they may start clawing back some of the money they're giving next year. But at that point, I guess we'll get there when we get there. But I think from a hospital perspective, it is a better outlook than if you're a single physician.
Dr. Erdik, thank you once again for your comments. Let's move to another area where our audience would very much benefit from your expertise. The 340B program that affects hospitals perhaps more than providers, but nevertheless is an important part of the overall healthcare landscape. Would you mind telling us about it?
Sure. I mean, as you all know, 340B program has been here for a while. The uptake has been good to the almost tune of $50 billion. Granted, there has been some issues. Let's say if I were to prescribe heparin and the nurse rolls it up, right, administers it, there's waste. So if they didn't document this in the EHR, or if the EHR wasn't somehow compliant, ultimately there may have become a point where you would be left with quote-unquote zero balance on your 340B sheet, where all your drugs would have been wasted, because it's typically a tit-for-tit replacement, where if you use one, you get to replace one. So there's been an ongoing issue. But beyond that, there were a couple lawsuits last year. There was the HRSA litigation, as well as a bunch of new laws in different states. The ones I remember are, there was an Arkansas one, there was an anti-discrimination one in Arizona. So there were been lots of changes both this year and last year. Ultimately, that's become also a point this year where Eli Lilly released a policy, and this policy ultimately forbade the 340B covered entities from designating their central pharmacies as exempted pharmacy locations. So these have been all ongoing from the manufacturer part to restricted. What ultimately cultivated is that the CMS agreed to pay each hospital in the 340B program a lump sum. So this is almost a $10 billion lump sum. But ultimately, I can even feel those in hospital settings right now thinking, oh, this is going to be such a great time. We're getting a lump sum payment. Yes, but if the right hand give it, the left hand take it away. So I suspect there's going to be lots of requirements and changes coming to it, because it's a big money that's being given. And one of the main ones is going to be is that the HRSA is going to require hospitals to register their outpatient clinics and list them on Medicare cost reports. A lot of the hospitals have not been happy about this, because honestly, I don't know, because my gut feeling is that the less data people share, especially if they're for a private for-profit hospital, the more confident they feel that they're not letting out their, I don't want to say dirty laundry, but trade secrets, if you dare have any as a hospital setting. But ultimately, that's a big change that's coming. And ultimately, TLDR, before push comes to shove, before you're looking down the barrel of these changes and the effects of these changes, I think it is the time now to sit down and figure out what your exposure to 340B is going to be. And maybe if you're a hospital with lots of outpatient settings where you provide care with biologics, reach out to your PBM, see if you can do some bundle deals with a lot of biosimilars that have been approved this year, and figure out what the way forward for your facility will be. This year has been a lot of changes when it comes to 340B and pharmaceuticals, but on the contrary, on the other side, there's also been lots of biosimilars approved for a lot of these expensive biologic drugs. So at the end of the day, you may actually not be stuck with the manufacturers as you suspect you may have been.
Thank you very much. Again, this is very timely and very important information, particularly for those in our audience who are involved with operating hospital-related facilities. There must be important changes on the provider side as well. Would you mind commenting on those?
Sure. From a provider side, we've been discussing the downsides. We've been discussing what the actual changes and then how when the inflation was rising, CMS has been cutting reimbursements. There is one good thing. There is one way you can now try to offset that reduction to the conversion factor that is about 3.3%. And that is the G2211. What is G2211? So it is a policy that the AFB has long advocated. It is an add-on code to pay for complex, high-value visits that mainly primary care physicians provide if they have a continuous relationship with the patient. Meaning they are trying to bolster the longitudinal primary care and change out, as we've discussed, from an episodic visit with the patient. So it is, I think, all up to the Congress to modernize Medicare's outdated physician payment system so that this budget neutrality ultimately doesn't keep cutting reimbursement for physicians. They also need to enact annual inflationary adjustments and provide relief from, dare I say, untenable reductions in physician payment, because there has to be a breaking point at somewhere in the future, right? There has to be a straw that'll break the camel's back. But ultimately, as a band-aid for this year, you may want to look into the possibility of billing G2211 alongside your outpatient evaluations, and where that is applicable, and hopefully that'll be a band-aid to the reduction to the conversion factor. I can hear people listening right now, well, we didn't really need that. We had modifier 25. So modifier 25 is what you claim if you were performing a procedure or providing, let's say, an annual wellness visit on the same day as an outpatient evaluation and management. Then there was going to be an exception for the annual wellness visit that would have allowed providers to use both the new code and modifier 25, but this is not reflected. So currently 25 and G2211 are exclusionary. You cannot combine them.
Again, very helpful. Thank you very much once again.
For those of you eager to delve deeper and perhaps have your regulatory questions addressed specifically, don't miss the exclusive opportunity to join Dr. Erdik for a live Q&A session. Stay connected and follow us on LinkedIn, Instagram, and YouTube to register for this interactive session and other installments in our Hygia Today series. Your engagement is important to us, and we welcome your feedback.